Okay, let's take a deep breath and dive into a really critical topic today.
Sounds good.
We're pulling directly from a core text we've been working with, specifically Chapter 70, which is, all about something we all need to understand better: the prevention and early detection of cancer.
And the source we're referencing, just so you know, comes from these excerpts of a document titled Harrison 250-116-1917-46-39.pdf. It's quite a substantial piece of work, provides a really comprehensive grounding in oncology and hematology concepts.
Right, and our mission for you, our listener, is to really go deep enough with this material that you can truly master it. We want you to understand the key strategies, the evidence that supports them, or sometimes doesn't.
Sure.
Well, the fundamental challenges involved in preventing cancer and finding it early.
Yeah, this isn't just a surface skim.
No, definitely not. We're aiming for that kind of depth that professionals in the field really grapple with. We've tailored this deep dive specifically for you to get you informed quickly, thoroughly, and hopefully with a real understanding of the nuances.
And it's helpful, I think, to know where this chapter fits in the bigger picture. Our focus is Chapter 70, Prevention and Early Detection of Cancer, but the source itself covers a much wider range of oncology topics.
Like what else?
Well, for instance, things like end-of-life discussions are covered elsewhere in Chapter 12. And the document also points you towards further reading if you want to dig deeper into related areas, things like specific global cancer statistics or maybe guidelines for managing nausea and vomiting, palliative care strategies, pain management. It's all part of that larger context of cancer care.
Okay, good context. So setting the stage with Chapter 70. The text kicks off by making a really fundamental point. Cancer isn't like, catching a cold. It's not sudden.
Right. The process of carcinogenesis, how cancer actually develops, usually extends over years. It's described as this complex continuum, a series of discrete changes in tissues and cells that just accumulate over time.
A slow burn, almost.
In a way, yeah. And because it is this long, multi-step process, the fundamental goals for reducing cancer deaths, as the source lays them out, really boil down to two main approaches.
Which are?
First, trying to stop cancer from developing in the first place in people who are at risk, that's prevention. And second, finding it at its earliest possible stages when it's often much more treatable, that's early detection, usually through screening.
They stop it before it starts,
Yeah.
or catch it when it's small. Makes sense. The text also really emphasizes the absolute necessity of having robust evidence to guide what we actually do.
Critically important.
Because looking at national patterns of disease, epidemiology, that gives us clues, indicators.
Sure, it points you in a direction.
But the best evidence for deciding which prevention strategies or screening tests are truly effective, especially when we're talking about applying them to healthy people, the general population, that comes from randomized trials.
Randomized controlled trials, or RCTs, they're really the bedrock. They're designed specifically to minimize bias and let us compare outcomes in groups of people who are otherwise similar. That gives us the clearest picture of whether an intervention or a test actually makes a difference in outcomes that matter, like, mortality.
Okay, so evidence is key. Let's start then with the first major strategy: prevention. The source describes this as identifying and then manipulating biological, environmental, social, even genetic factors that are part of that causal pathway leading to cancer.
And a cornerstone of prevention, maybe the most fundamental part, is broad public education and encouraging healthful habits. The text really stresses how crucial public education is for informing people about avoiding known risk factors and promoting those healthy behaviors that can genuinely lower risk.
And this is where the clinician, the doctor or nurse, really comes in, right? The source highlights that the patient-provider encounter itself is a really powerful opportunity.
Absolutely. It's a chance to educate individuals directly about their personal risks. Things like smoking, lifestyle choices, maybe specific environmental or occupational exposures they might have, and also to encourage them to participate in screening methods that we know work.
So it's not just about treating illness, it's this proactive health moment.
Exactly. It's a health promotion opportunity.
Okay. And if we're talking identified risk factors, we probably have to start with, the big one: tobacco.
No question. The source identifies smoking as a strong, modifiable risk factor, and it contributes hugely not just to cancer, but also to cardiovascular and pulmonary diseases.
And the numbers are they're really eye-opening. The text states that smokers face about a 1 in 3 lifetime risk of dying prematurely from something related to tobacco cancer, heart disease, lung disease.
It's a staggering statistic.
And here's a detail from the source that surprised me. Tobacco use actually causes more deaths from cardiovascular disease than from cancer. That really puts the total harm into perspective, doesn't it?
It certainly does. It's not just about lung cancer. Far from it. The source lists a whole range of specific cancers strongly linked to smoking. Lung, obviously, but also larynx, the oropharynx, that's the back of the throat, esophagus, kidney, bladder, colon, pancreas, and others. It's a long list.
Wow.
And it also notes that clear relationship. The longer you smoke and the more you smoke, the higher your risk of dying from lung cancer. It's dose dependent.
And for anyone thinking they found a loophole, like light or low-tar cigarettes,
Yeah, the text explicitly debunks that idea. They are not safer. Smokers just compensate. They inhale more frequently or more deeply to get the nicotine hit they're addicted to. So no benefit there.
but there is good news, powerful positive news. The benefits of quitting are substantial.
Huge. The text highlights that people who stop smoking have a 30 to 50% lower 10-year lung cancer mortality rate compared to those who keep smoking.
That's a massive reduction.
It really is. And it's significant even though some of the genetic damage, the mutations caused by the carcinogens, can actually persist for years after someone quits. It just shows that stopping the exposure, even later on, still has a major, major impact.
And thinking about this at a population level, the source makes this really emphatic statement. Smoking cessation and avoidance would save more lives than any other public health activity.
That's the bottom line. It's almost hard to grasp the scale of the potential impact.
And the harm isn't just to the smoker, right? Secondhand smoke.
Environmental tobacco smoke, or passive smoke, yes. It's confirmed as carcinogenic, no question. And it's also linked to other health problems, particularly respiratory illnesses in kids who are exposed.
Which brings us to a really critical point the source makes. Preventing tobacco use is fundamentally a pediatric issue.
That's right, because the vast majority of adult smokers started young. The text says more than 80% of American adult smokers began before they turned 18.
And while traditional cigarette smoking rates have thankfully dropped among high schoolers down to about 8% in a recent survey month,
Which is good news.
there's been this dramatic and, frankly, pretty concerning rise in electronic cigarette use in vaping. The stats mentioned are around 28% of high school students and 11% of middle school students using e-cigarettes recently.
That explosion in youth vaping is a huge public health challenge right now. It really underscores how urgent it is to counsel adolescents and young adults to prevent them from starting any form of tobacco use.
And the good news, maybe,
Yeah.
is that even simple advice from a doctor or nurse can help.
Yes, the source says a clinician's simple advice can be of benefit. Providers really should make it routine practice to ask about tobacco use and offer help to quit.
And quitting is hard. Nicotine is addictive.
Extremely. The text outlines the process people go through: contemplation, thinking about it, action, actually quitting, and then maintenance, staying quit. And generally, success is more likely if people quit completely cold turkey rather than trying to cut back slowly or switch brands.
Support helps.
Definitely. Organized programs, especially for heavy smokers, can make a big difference. These often combine counseling, behavioral strategies, and sometimes medication.
What medications are mentioned?
The source lists the main options. Nicotine replacement therapies, things like gum, patches, sprays, lozenges, inhalers, and also prescription meds like bupropion and varenicline. Sometimes combinations are used.
Okay. Now, what about e-cigarettes as a tool to help people quit regular cigarettes?
Yeah, that's a contentious area. The text mentions they are sometimes advocated for that purpose in adults, but the key takeaway is that their effectiveness for smoking cessation is currently unknown. We don't have solid proof they work well for that.
And the long-term health effects.
Also largely unknown. The source says the net effects on overall health are poorly studied, and it highlights a serious risk. The lack of strict manufacturing controls over the liquids, the juice, has actually led to serious injuries in some cases.
That's worrying. What about other forms of tobacco, like cigars or smokeless?
The source covers those too. Cigars carry similar health risks to cigarettes. Smoking just 1 or 2 a day doubles the risk for oral and esophageal cancer. 3 or 4 a day. That jacks up the oral cancer risk more than 8-fold and esophageal 4-fold.
What about just occasional cigar use?
The text states the risk there is unknown.
And smokeless tobacco. Chewing tobacco. Snuff.
Also poses a substantial health risk. It's linked directly to dental problems like cavities and gum disease, oral leukoplakia, those precancerous white patches, and of course oral cancer itself. Plus, there might be systemic effects increasing risks for other cancers. And swallowing the carcinogens dissolved in saliva is linked to esophageal cancer risk. Like e-cigs, the net long-term health effects are still not fully understood in all areas.
Okay, so tobacco is clearly priority number 1 for prevention. Let's shift gears. Physical activity.
Yes, Discussed next. It's consistently associated with the decreased risk of colon and breast cancer. And there are plausible biological reasons proposed for why that might be.
But studying it is tricky.
Very tricky. The source points out these studies are prone to biases. Like recall bias, can people accurately remember how much they exercised years ago? And confounding people who exercise more often have other healthy habits too. And even reverse causality, maybe an undetected cancer is making someone tired, so they exercise less, making it look like lack of exercise caused the cancer. It's hard to isolate the effect.
Right. What about diet modification? Another complex area, I imagine.
Extremely complex. International epidemiologic studies looking at large populations have suggested that diets high in fat are associated with increased risk for cancers of the breast, colon, prostate, and endometrium.
But there's always a but in diet research, isn't there?
Often, yes. And the really crucial caveat emphasized here is, despite these associations, dietary fat has not been definitively proven to cause cancer. Case control studies and cohort studies give conflicting results.
Why is it so hard to study?
Well, diet is just incredibly complex. It's not just one thing. And people who adopt low-fat diets often change many other things about their lifestyle simultaneously. They might eat more fruits and vegetables, exercise more, be more health conscious overall. So isolating the effect of just the fat is really difficult.
What about fiber, fruits, and vegetables specifically?
Some observational studies have linked higher dietary fiber intake to lower risk for breast, colon, and other cancers, and others have linked high fruit and vegetable intake to lower risk for lung, esophagus, oral cavity, and larynx cancers. So suggestive correlations. However, and this is a really important point from the text, prospective clinical trials designed specifically to test these ideas have not shown clear cancer protective effects from increasing fiber or lowering dietary fat.
Can you give an example?
Sure. The polyp prevention trial. They took people who'd had colon polyps removed and randomized them to either a low-fat, high-fiber, high-fruit and veg diet or just the usual diet. After 4 years, no difference in new polyp formation.
And the Women's Health Initiative, that was huge.
Massive trial. The women in the dietary intervention group did manage to lower their fat intake compared to the control group, but over 8 years, there was no reduction in invasive breast cancers, and similarly, no reduction in colorectal cancer incidence.
So the observational links didn't hold up in rigorous trials. That's a common theme, it seems.
It highlights the difference between correlation and causation, definitely.
What about red and processed meat?
The source reviews cohort studies and randomized trials and concludes they suggest a small effect, if any, on overall cancer incidence and mortality. The overall evidence base is considered weak.
Then vitamin, mineral, nutritional supplements, taking extra beyond a normal diet.
The text is pretty clear here. The evidence currently does not establish any anti-carcinogenic value from taking supplements in amounts greater than what you'd get from a balanced diet.
Okay. What about energy balance, essentially body weight or BMI?
There's an association there. The source states that the risk of certain cancers seems to increase modestly relative risks, usually between 1.0 and 2.0 as body mass index, or BMI, goes up above 25 kilobrometer remota, which is the threshold for overweight.
Any specifics?
Yeah, a very large UK study, over 5 million adults, found that each 5 kilobrometer increase in BMI was linearly associated with increased risk for cancers of the uterus, gallbladder, kidney, cervix, thyroid, and also leukemia.
Interesting. But it also mentions an inverse association, lower risk with higher BMI for some cancers.
That's right. High BMI appears to be inversely associated, meaning linked to lower risk with prostate cancer and premenopausal breast cancer. The reasons for that aren't fully clear.
Fascinating. Okay, next prevention topic, sun avoidance.
Crucial for preventing skin cancers. Non-melanoma skin cancers, basal cell and squamous cell carcinomas are largely caused by cumulative UV exposure over a lifetime.
And melanoma, the more dangerous kind.
Sunburns, especially blistering ones during childhood and adolescence, seem to be particularly associated with an increased risk of developing melanoma later in adulthood. So avoiding those intense exposures is key.
How can people reduce exposure?
Practical things. Protective clothing, wide-brimmed hats, sunglasses, seeking shade, and adjusting outdoor activity patterns to avoid the peak sun hours, typically midday.
What about sunscreens? They seem like the obvious answer.
They help, but it's nuanced. The source says sunscreens do decrease the incidence of actinic keratosis, those rough, scaly patches that are precursors to squamous cell carcinoma. However, they may not reduce the risk of melanoma.
Why not? That seems counterintuitive.
The proposed reason is interesting. Sunscreens are very good at preventing sunburn, which is largely caused by UVB rays. But melanoma risk might be more linked to UVA rays or just overall cumulative dose. So by preventing the burns, sunscreen might allow or even encourage people to spend more prolonged time exposed to those melanoma-causing wavelengths without getting the warning signal of a burn.
So behavior change might be more important.
Potentially. The text mentions that interventions focusing on appearance, like avoiding tanning to prevent wrinkles, might actually be more effective in getting young women to reduce UV exposure from things like indoor tanning beds compared to just warning about long-term cancer risk. And simply recognizing your personal risk factors makes you more likely to take precautions.
What are the specific melanoma risk factors listed?
A natural tendency to sunburn easily, having a large number of normal moles, benign melanocytic nevi, and the presence of atypical moles, atypical nevi.
Okay, so we've covered lifestyle factors, environment. Now let's transition to more specific, sort of targeted interventions discussed as prevention strategies. Chemoprevention, vaccines, and surgery.
Right. Starting with chemoprevention, this is defined as using specific agents, they could be natural substances or synthetic drugs, with the goal of reversing, suppressing, or preventing that whole carcinogenesis process before an actual invasive cancer develops.
So intervening earlier in that multi-step process we talked about.
Exactly. The idea is to target the points where you have these accumulated tissue or cellular abnormalities, genetic or epigenetic changes, or maybe altered growth pathways. These are all potential spots for intervention.
How does it relate to the stages of cancer development?
Cancer development is often described in stages: initiation, promotion, and progression. Initiation is the first hit, the initial damage, often genetic, maybe from a carcinogen or inherited. Promotion is when initiated cells are stimulated to grow and progress further. Progression involves more mutations leading to malignancy. Chemopreventive agents can potentially interfere at any of these points.
Initiation involves carcinogens. You mentioned the source has a table.
Yes, Table 71, it lists numerous established human carcinogens and the cancers they're linked to. We mentioned tobacco smoke already, linked to so many, but others include things like alkylating agents used in chemotherapy, potentially causing leukemia or bladder cancer down the line. Aromatic amines from certain industries linked to bladder cancer. Arsenic lecroskin, asbestos lumpler-baritonium, benzene leukemia, chromium lung, DES diethylstilbestrol, vaginal cancer in daughters of women who took it.
Hormones too.
Yes. Estrogens are listed linked to endometrial, liver, and breast cancer. Ethyl alcohol, breast, liver, esophagus, head, neck.
Infectious agents.
Absolutely. H. pylori, gastric cancer lymphoma. HIV, less certain lymphomas and sarcomas. HPV, lesser cervix, anus, or pharynx. Hepatitis B and C, liver cancer. EBV, Burkitt's lymphoma. Nasopharyngeal cancer. HTLV-1, a type of leukemia lymphoma.
Wow. Radiation, sunlight. Yep. Ionizing radiation, many cancers. Sunlight, skin cancer. Radon gas, lung cancer, even things like nickel dust, diesel exhaust, certain industrial chemicals like vinyl chloride, liver angiosarcoma, schistosomiasis, a parasitic infection, bladder cancer. It's a diverse list showing cancer arises from interactions between genetics and environment.
And some agents can be both initiators and promoters. Correct. The distinction isn't always sharp. Some things, like components in cigarette smoke, are considered complete carcinogens. They can both initiate and promote tumor development. Promoters, like hormones, androgens for prostate, estrogen for breast endometrium, influence initiated cells to progress.
And the chemopreventative compounds themselves, what do they do?
They often have specific activities. They might be anti-mutagenic, prevent DNA damage, modulate hormone levels, reduce inflammation, slow down cell proliferation, or encourage apoptosis, program cell death, or sometimes a combination.
Let's look at some specific cancers where this has been studied, starting with cancers of the upper aerodigestive tract, head, neck, lung, esophagus. We know smoking is huge.
Yes, smoking causes widespread damage to the lining of these areas. And a key group highlighted for chemoprevention studies are patients already cured of a squamous cell cancer in this region.
Why them specifically?
Because they are at a very high risk. The text says up to 5% per year of developing a second primary cancer somewhere else in that same upper aerodigestive tract area.
And quitting smoking doesn't eliminate that risk entirely for them.
Counterintuitively, no. The source notes that quitting, while essential for overall health, does not markedly decrease this risk of a second malignancy in these already cured patients, unlike its huge effect on preventing a first cancer. Quitting might help halt early precancerous changes like oral leukoplakia, though. This makes this population a really important target for trying to prevent that second cancer.
What about HPV in this context?
Oral HPV infection, especially HPV-16, is a big risk factor for oropharynx cancers, even in people who don't smoke or drink, though the risk is much higher if you combine those factors. It's thought to be sexually acquired.
Could the HPV vaccine help prevent these oral cancers?
Potentially. The text mentions the vaccine is associated with lower rates of oral HPV infection, so it may eventually reduce oropharyngeal cancer rates. But the evidence isn't definitive yet. And unlike cervical cancer, we don't have a well-defined precursor lesion for these oropharyngeal tumors that we can track easily.
Okay. What about using something like oral leukoplakia, those white patches, as a marker in trials?
It has been used as an intermediate marker. High doses of isotretinoin, a vitamin A derivative, did cause regression of these lesions, but the text states that more tolerable doses haven't shown benefit in actually preventing head and neck cancer in larger trials.
And what about large-scale trials trying to prevent lung cancer with chemoprevention in high-risk folks, like smokers?
Several big ones were done with, unexpected results. The ATBC trial in male smokers in Finland tested alpha-tocopherol, a form of vitamin E, and beta-carotene. After about 6 years, the guys taking beta-carotene actually had a statistically significant increase in lung cancer incidence and death.
An increase. Wow.
Yes. Alpha-tocopherol didn't affect lung cancer deaths, but was linked to more hemorrhagic strokes.
And the Kerry trial.
That was in the U.S. with smokers and asbestos workers. It also tested beta-carotene along with retinol vitamin A, and it too demonstrated harm from beta-carotene, increasing the lung cancer rate. It was stopped early.
So these trials are a pretty stark warning.
Absolutely. The source emphasizes this. ATBC and CARROT highlight the critical importance of thoroughly testing chemoprevention ideas in rigorous trials before suggesting them widely. Observational studies might look promising, but trials can reveal unexpected harms or simply show they don't work. What seems logical isn't always true biologically.
Okay, let's shift to chemoprevention of colon cancer. What's the premise there?
It's largely based on the fact that most colorectal cancers develop from adenomatous polyps. So many trials use the recurrence or disappearance of these polyps as a surrogate endpoint, a stand-in for preventing cancer itself. Though the source notes this link isn't fully validated yet.
What agents have been studied?
NSAIDs, non-steroidal anti-inflammatory drugs like piroxicam, Cilindac, and aspirin. Clinical trial results suggest they may prevent new adenoma formation or even cause existing ones to regress. The mechanism isn't totally clear, but likely involves blocking the cyclooxygenase COX enzymes.
Aspirin seems to get a lot of attention.
It does. A meta-analysis combined data from 4 large randomized trials, which were actually designed primarily to look at cardiovascular effects, found something interesting. Taking aspirin, at least 75 milligrams a day, resulted in about a 33% relative reduction in colorectal cancer incidence when people were followed for 20 years. Higher doses didn't seem clearly better.
And this influenced guidelines.
Yes. Based largely on this data from the cardiovascular prevention trials, the USPSTF guidance favors initiating low-dose aspirin for preventing both colorectal cancer and cardiovascular disease in adults aged 50 to 59 who have at least a 10% risk of a cardiovascular event over the next 10 years.
But not for older adults.
That's a key caveat. The source points out that low-dose aspirin does not appear to benefit the elderly for cancer prevention. A big trial called ASPIRI tested daily low-dose aspirin in healthy older adults and was stopped early because it showed no benefit for major outcomes, including cancer.
What about other anti-inflammatories, like the COX-2 inhibitors, Celebrex, Vioxx?
They were considered for prevention because they target COX-2, which is often upregulated in polyps and cancers. But trials showed significant cardiovascular and gastrointestinal toxicity. So the text concludes they are not suitable for chemoprevention in the general population.
Any other agents? What about hormone therapy from the Women's Health Initiative?
Right. We mentioned WHI before for breast cancer. That trial also found that postmenopausal women taking the combined estrogen plus progestin hormone therapy had a 44% lower relative risk of developing colorectal cancer compared to the placebo group.
That sounds good.
It does, but, and this is the crucial context the source provides, this positive effect on colon cancer risk has to be weighed against the modest increases in cardiovascular risks like stroke and blood clots and breast cancer risk associated with that specific combined hormone therapy. It's a classic risk-benefit trade-off.
Okay. Statins, used for cholesterol, any effect on colon cancer?
Early reports suggested a reduced risk, but most subsequent case control and cohort studies have not confirmed this. The text notes there have been no randomized controlled trials specifically testing statins for colon cancer prevention, and a meta-analysis looking at overall cancer showed no protective effect on cancer incidence or death.
All right, let's move to chemoprevention of breast cancer. Tamoxifen is a big name here.
It is. Tamoxifen is an anti-estrogen, but it's complex. It actually has partial agonist or estrogen-like activity in some tissues, like the endometrium and bone. In the breast, its main mechanism is thought to involve increasing TGF-beta, which helps slow down breast cell proliferation.
And the prevention trial result?
Very significant. A large randomized placebo-controlled trial, the Breast Cancer Prevention Trial, or PAVE, involved over 13,000 women considered high risk based on age, family history, etc. It found that taking tamoxifen for about 5 years decreased the risk of developing invasive breast cancer by 49%.
Almost half the risk.
Pretty much. From about 43 cases per 1,000 women down to 22 per 1,000 over roughly 6 years of follow-up. It also reduced bone fractures due to that estrogen-like effect on bone.
But risks too.
Yes. The text notes a small but real increase in the risk of endometrial cancer because of the estrogen effect there, stroke, pulmonary emboli, blood clots in the lungs, and deep vein thrombosis, clots in the legs. Other big trials, like EBUS in Europe and an Italian trial, also showed a reduction in breast cancer incidence with tamoxifen.
What about raloxifene? It's also used for osteoporosis.
Right. Raloxifene is a different type of SERM-selective estrogen receptor modulator. It was directly compared to tamoxifen in a large trial called STAR, specifically in postmenopausal women at high risk. The result: comparable effectiveness for preventing invasive breast cancer.
But with any differences in side effects?
Yes, and this was key. Raloxifene did not carry that increased risk of endometrial cancer seen with tamoxifen. It was associated with a slightly smaller reduction in invasive breast cancers overall compared to tamoxifen, and maybe a trend towards more non-invasive cancers. But importantly, it caused fewer thromboembolic events, blood clots. Risks for other cancers, fractures, heart disease, and stroke were similar between the two.
So both are options.
Yes. Based on this evidence, the FDA has approved both tamoxifen for pre- and postmenopausal high-risk women and raloxifene for postmenopausal high-risk women only, specifically for breast cancer risk reduction. High risk is typically defined using the Gale model, needing a 5-year projected risk of 1.66% or higher.
What about the aromatase inhibitors, like Arimidex, Femara?
These are another class of hormone therapy, even more effective than tamoxifen in the treatment of existing estrogen receptor-positive breast cancer. So the hypothesis was they might be even better at prevention.
And was that tested?
Yes. A large, randomized, placebo-controlled trial tested exemestane, aromacin, an aromatase inhibitor, in high-risk postmenopausal women. After about 3 years, it reported a striking 65% relative reduction in invasive breast cancer incidence compared to placebo. That's going from 5.5 cases per 1,000 women down to 1.9 per 1,000.
Significant reduction.
Side effects. Common ones mentioned are joint pain, arthralgias, hot flashes, fatigue, and insomnia, more related to estrogen deprivation.
Has anyone compared aromatase inhibitors directly to tamoxifen or raloxifene for prevention?
That's a key evidence gap, the source points out. No trial has directly compared an aromatase inhibitor with a SERM head-to-head specifically for breast cancer chemoprevention, so we don't know for sure which is best in that setting.
Okay, one more chemoprevention area, prostate cancer. What agents have been studied?
The main ones are finasteride, Proscar, and dutasteride, Avodart. These are 5-alpha reductase inhibitors. They block the enzyme that converts testosterone into dihydrotestosterone, or DHT. DHT is a potent stimulator of prostate cell growth.
And the big trial was the PCPT.
Right, the Prostate Cancer Prevention Trial. It took over 18,000 men, aged 55 or older, considered average risk, but who were all undergoing regular screening with PSA tests and digital rectal exams, DRE. They were randomized to finasteride or placebo.
What did it find?
After 7 years, the overall incidence of prostate cancer diagnosis was statistically significantly lower in the finasteride group, 18.4% versus 24.4%, so fewer cancers detected.
Sounds positive. Was there a catch?
Yes, there was. And this is where it gets really complicated. The finasteride group actually had more men diagnosed with higher grade tumors, those with a Gleason score of 7 or higher, which indicates more aggressive cancer. It was 6.4% in the finasteride group versus 5.1% in the placebo group.
More aggressive cancers. That sounds bad.
It caused a lot of concern and debate. However, long-term follow-up of the PCPT, out to 10 or 15 years, did not reveal any statistically significant differences in overall mortality or death specifically from prostate cancer between the two groups, or among the men who were diagnosed. But the study might have lacked the power to detect a small difference in mortality.
Was there another trial with the other drug, dutasteride?
Yes, the RADC trial. It studied dutasteride in about 8,200 men who had an elevated PSA level but had already had a negative prostate biopsy. Compared to placebo, dutasteride led to a statistically significant 23% relative risk reduction in the incidence of biopsy-detected prostate cancer over 4 years.
And the high-grade tumor issue?
Similar pattern, but slightly different. Overall, no difference in Gleason 7-10 tumors. But specifically in years 3 and 4 of the trial, there was a significant difference in the very highest grade tumors, Gleason 8-10, with 12 cases in the dutasteride arm versus only 1 in the placebo arm.
So this controversy about higher grade tumors persists. What's the explanation?
The most likely explanation, favored by many experts and mentioned in the source, is what's called detection bias. These drugs shrink the overall prostate gland volume. This might make PSA testing and DRE more sensitive at detecting the high-grade cancers that are present, simply because the gland is smaller and the cancer is relatively easier to find.
So it's not causing more aggressive cancer, just finding it better?
That's the theory. BUT, and this is crucial. The FDA, when reviewing these drugs, acknowledged that detection bias might explain the findings, but they felt a causative role that the drugs somehow promote high-grade cancer could not be conclusively dismissed. Because of this lingering uncertainty, these agents are not FDA approved for prostate cancer prevention.
And another key limitation you mentioned earlier.
Right. All the men in both PCPT and REDUCE-CC were being regularly screened. Screening itself roughly doubles the detection rate of prostate cancer. So we don't know if these drugs actually reduce the risk of prostate cancer in men who are not screened, or if they mainly just reduce the risk of finding those less aggressive screen-detected cancers that might never have caused harm anyway.
Big questions remain. Any other agents tried for prostate cancer prevention?
Yes, selenium and vitamin E, specifically alpha-tocopherol, were studied in the huge SELECT trial over 35,000 men. This was based on promising lab studies and some observational data.
And the result?
Similar to the beta-carotene story in lung cancer. The trial was stopped early because there was actually a trend toward an increased risk of prostate cancer observed for men taking vitamin E alone compared to placebo. Selenium showed no benefit. Another cautionary tale about relying on observational data for prevention.
Indeed. Okay, let's pivot from drugs to another powerful prevention strategy. Vaccines.
Right. The link here is clear, as the source establishes. A number of infectious agents are known causes of human cancer.
We saw some on that carcinogen list earlier.
Exactly. Examples include hepatitis B and C viruses causing liver cancer, certain strains of human papillomavirus, HPV, causing cervical, anal, and head and neck cancers, and the bacterium Helicobacter pylori causing gastric adenocarcinoma and a type of stomach lymphoma called malt lymphoma.
So the logic is, if you vaccinate against the infection,
you may therefore reduce the risk of the cancers associated with that infection.
And we have examples where this works.
Absolutely. The hepatitis B vaccine is cited as being very effective in preventing chronic hepatitis B infection and, consequently, the liver cancers, hepatomas, that arise from chronic infection.
What about the HPV vaccine? Huge public health effort there.
Yes. The currently available non-valent vaccine in the U.S. covers 9 HPV types. 2 of them, 6 and 11, cause most genital warts. The other 7, including the major ones, 16 and 18, plus 31, 33, 45, 52, 58, are high-risk types responsible for the vast majority of cervical cancers, as well as many anal, vaginal, vulvar, penile, and oropharyngeal cancers. Strains 16 and 18 alone could prevent over 70% of cervical cancers worldwide.
And it works well.
Very high efficacy, yes, in preventing persistent infections with the specific HPV types covered by the vaccine in individuals who haven't already been infected with those types. It's also been shown to prevent the development of preneoplastic lesions, CIN and AN grades both 3-3, which are the precursors to invasive cervical and anal cancers.
Are there limitations?
A couple mentioned. The durability of the immune protection beyond 10 to 12 years is not currently known, although studies are ongoing. And critically, the vaccine does not appear to impact or clear HPV infections that a person already has at the time of vaccination. It's purely preventive.
What's the recommended schedule in the U.S.?
It's age-based. For those starting the series young, between ages 9 and 14, it's typically a 2-dose schedule. For those starting later, ages 15 through 26, it's a 3-dose schedule. The text also notes some emerging data. Observational studies suggest similar efficacy might be achieved with just a single dose in young girls, and a large trial is underway comparing 1 versus 2 doses directly.
And H. pylori, was that mentioned as vaccine preventable?
It was listed in the source text section about infectious agents causing cancer, where vaccines might reduce risk, linking it to gastric cancer and lymphoma. However, the text doesn't actually detail a specific H. pylori vaccine being available or widely used for this purpose currently, just that the infectious link exists.
Got it. Okay, the last specific prevention strategy discussed is surgical prevention.
Right. This involves surgically removing an organ that is deemed to be at a very high risk of developing cancer, usually because of a strong inherited genetic predisposition or a specific precancerous condition in that organ.
What are some examples?
Colectomy, removing the colon, is a standard approach to prevent colon cancer in patients who have inherited conditions like familial adenomatous polyposis, FAP, where they develop hundreds or thousands of polyps, making cancer virtually inevitable. Or sometimes in severe, long-standing ulcerative colitis, which also carries a very high cancer risk.
And for breast cancer risk?
Prophylactic bilateral mastectomy, removing both breasts, is an option chosen by some women with a very strong genetic predisposition, most notably those carrying mutations in the BRCA1 or BRCA2 genes.
Is there data on how well that works?
Yes, the source provides some data. One prospective study followed 139 women with BRCA mutations. 76 chose preventive mastectomy, while 63 opted for intensive surveillance, like frequent MRI and mammograms. After 3 years, no breast cancers were diagnosed in the surgery group compared to 8 cancers diagnosed in the surveillance group.
That's a striking difference.
It is. And a larger retrospective study looked at 639 women with BRCA mutations who had preventative mastectomy. They found only 3 breast cancers occurred after surgery, whereas based on their risk level, you would have accepted somewhere between 30 and 53 cancers. Breast cancer deaths were also dramatically lower in the surgery group compared to what was expected.
What about preventing ovarian cancer in high-risk women?
Prophylactic salpingo-oophorectomy, surgically removing both the ovaries and the fallopian tubes, is recommended for women with BRCA12 mutations after they've completed childbearing, typically around age 35-40 for BRCA1, and maybe slightly later for BRCA2. This surgery can prevent both ovarian and breast cancers.
Evidence for ovarian cancer prevention.
A prospective cohort study of BRCA carriers found a statistically significant association between having the surgery and a reduced incidence of ovarian or primary peritoneal cancer, about a 36% relative risk reduction.
And for breast cancer prevention, does removing ovaries help?
Yes, because it drastically reduces estrogen levels. Studies show relative risks for breast cancer around 0.50, a 50% reduction, in BRCA carriers who have their ovaries removed. The risk reduction seems potentially greatest for women who have the surgery before age 50.
The source mentions a nuance about where these ovarian cancers actually start.
Right. There's growing evidence that many, perhaps most, high-grade serous cancers, which are the most common and lethal type thought of as ovarian cancer, actually originate in the fimbria, the finger-like ends of the fallopian tubes. This has raised the possibility that maybe just removing the fallopian tubes, salpinectomy, while leaving the ovaries intact, at least until natural menopause, might be sufficient to prevent this deadly subtype while avoiding premature menopause. That's an area of active research.
Now, a crucial caveat about all this surgical prevention data.
Yes, absolutely critical and highlighted explicitly in the text. All the evidence we have for prophylactic mastectomy and salpingo-oophorectomy in high-risk women comes from observational studies. There are no randomized controlled trials comparing surgery to surveillance for these outcomes.
And why is that a problem?
Because observational studies are prone to various biases. For example, women who choose surgery might be different in other ways, maybe more health conscious, maybe different family structures, from those who choose surveillance. It's hard to ensure the groups are truly comparable. Information on other factors, like hormone use after ovary removal, might be incomplete. Because of these potential biases, the text warns that these observational studies may give an overestimate of the true magnitude of the benefit. The benefit is likely real and substantial, but the exact percentage reduction might be slightly inflated by the study designs.
Important context for interpreting those numbers. Okay, let's transition now. We've covered prevention, trying to stop cancer from starting. Now let's tackle the second major strategy: cancer screening or early detection.
Right. Screening is defined as using tests or procedures to look for cancer or precancerous lesions in people who don't have any symptoms. The ultimate goal is to decrease morbidity and mortality from the cancer.
And the text says it has been shown to reduce deaths for some cancers.
Yes. Specifically mentioned are cervical, colon, lung, and breast cancer. For these, we have evidence that screening can, under certain conditions, lead to fewer people dying from the disease.
But, sounds like there's a big but coming.
There is. This is where understanding the nuances and complexities is absolutely critical. The text highlights right up front that screening is subject to a number of biases that can make a test look beneficial when it isn't, or they can even hide potential harm.
And just finding cancer earlier isn't automatically good.
Exactly. That's a key point, often misunderstood. Early detection in itself does not confer benefit. Just finding a cancer earlier is only helpful if finding it earlier leads to more effective treatment that actually changes the course of the disease and improves the patient's outcome, like extending their life or reducing suffering.
Which is why the endpoint used to judge screening is so important.
Precisely. The preferred endpoint for evaluating whether a screening test truly works is cause-specific mortality. Do fewer people die from that specific cancer in the screened group compared to the unscreened group? That's the gold standard. Measuring survival after diagnosis is problematic.
Why is survival after diagnosis misleading?
Because screening, by definition, finds cancers earlier. So even if the treatment doesn't change the time of death at all, the person will appear to survive longer simply because the clock started earlier. The text explains this can inflate survival statistics without actually prolonging life. You just spend more time knowing you have cancer.
That makes sense. And since screening involves testing healthy people,
the bar for recommending it widely has to be high. The text states it should offer a substantial likelihood of benefit that clearly outweighs the potential harms. Screening tests, and the way they're used, must be carefully and critically evaluated.
The source also briefly touches on using genetic mutations and polymorphisms for screening, identifying high-risk people.
Yes. We know of a large and growing number of these genetic variations associated with increased cancer risk. The theory is maybe we can test for these to identify a high-risk population that would benefit most from screening or prevention.
It's not that simple.
Not yet, really. The reality is that most of the identified mutations associated with common cancers have very low penetrance. That means most people who carry the mutation will never actually develop the cancer. So individually, these common variants have limited predictive accuracy for any given person.
What about the future?
Well, the text speculates that maybe someday, as our understanding grows, genetic risk prediction might allow for more targeted early intervention or prevention strategies. High-risk individuals might be ideal candidates for intensive screening or chemoprevention. But and this is important, the efficacy of these interventions, specifically in genetically defined high-risk populations, needs to be investigated. We can't just assume they'll work better. Intensive screening for known high-risk individuals, like BRCA carriers, is considered clinically reasonable, but it's currently not known for sure if it actually reduces mortality in these specific groups compared to standard approaches.
Okay, so let's get into the nuts and bolts of how screening tests perform and their limitations, referencing Table 72 from the source. There are 4 key measures, right?
Yes. Sensitivity, specificity, positive predictive value, PPV, and negative predictive value, NPV. Understanding these is crucial for interpreting test results.
Let's break them down. Sensitivity.
Sensitivity is the proportion of people who actually have the disease and test positive. It's the test's ability to correctly detect the disease when it's truly there. A highly sensitive test misses very few cases, few false negatives.
Specificity.
Specificity is the proportion of people who do not have the disease and test negative. It's the test's ability to correctly identify someone as disease-free. A highly specific test has very few false positives.
Okay. Sensitivity finds the disease, specificity rules it out. What about PPV?
Positive predictive value is maybe the most important for someone getting a test result. It's the proportion of people who get a positive test result and actually do have the condition. So if your test is positive, what's the chance you really have the disease?
And NPV.
Negative predictive value is the flip side. It's the proportion of people who get a negative test result and actually do not have the condition. If your test is negative, how confident can you be that you're disease-free?
Now, the source says these values relate to how common the disease is.
Critically important point. Sensitivity and specificity are characteristics of the test itself. They don't change much based on who you test. But the predictive values, PPV and NPV, depend strongly on the prevalence of the disease in the population being tested.
How so?
Screening works best, meaning a positive test is more likely to be a true positive, high PPV, when the target disease is relatively common in the group being screened.
And for cancer screening in the general population, cancer is usually not common, right?
Exactly. Most cancers have a relatively low prevalence in asymptomatic people. This means that specificity becomes at least as important as sensitivity, maybe even more so.
Why is specificity so crucial when prevalence is low?
Because even a test with very good specificity, say 95%, meaning only 5% false positives, when applied to a large population where the disease is rare, say 1 in 1,000, will generate far more false positives than true positives. If you test 1,000 people, you'll find maybe 1 true positive, but you'll get about 50 false positives, 5% of the 999 healthy people. In that scenario, your PPV is terrible. Only 1 out of 51 positive tests is real. This leads to a huge number of healthy people getting unnecessary follow-up tests, anxiety, and cost.
Wow, that really illustrates the challenge. And this ties directly into the potential biases of screening tests, the source details.
Yes, these biases are critical to understand because they can create the illusion that screening is beneficial even when it's not, or even when it's causing net harm. Screening can also create a false impression of a cancer epidemic just by finding more cases that were already there, dormant.
And it can make survival stats look better without actually helping people live longer.
Correct. Screening often shifts the diagnosis to an earlier stage without necessarily reducing the number of people who eventually develop advanced life-threatening disease. This inflates survival statistics measured from the time of diagnosis because people simply spend longer knowing they have the disease, but their actual lifespan isn't extended.
Let's define those specific biases. Lead time bias.
Lead time bias occurs because screening detects the cancer earlier in its natural history than it would have become symptomatic. So the time from diagnosis to death will automatically be longer, even if the actual time of death doesn't change. The lead time gained by early diagnosis makes survival appear increased. Screening, in this case, only prolongs the time the person is aware of their diagnosis and lives as a cancer patient.
Okay. Length-biased sampling.
Length bias happens because screening tests done periodically are inherently more likely to detect slower-growing, less aggressive cancers. Why? Because those cancers exist in a detectable preclinical state for a longer period, offering more opportunities for screening to find them. Faster-growing, more aggressive cancers might develop and cause symptoms between screenings.
So the cancers found by screening tend to be the better ones anyway.
On average, yes. They have a longer natural history and often a better prognosis, regardless of whether they were found by screening or symptoms. This makes the group diagnosed through screening look like they have better outcomes, but it might just be because screening preferentially finds the less dangerous tumors.
And overdiagnosis, you mentioned that earlier.
Overdiagnosis is considered an extreme form of length bias. It's the detection of what the text calls pseudo-disease. These are lesions that meet the pathological definition of cancer under a microscope, but they are so slow-growing or indolent that they will never progress to cause symptoms or lead to death during the patient's natural lifespan.
So you're finding cancers that wouldn't have mattered.
Exactly. There appears to be a large reservoir of these undetected, slow-growing tumors, particularly for cancers like prostate and breast, and potentially thyroid and melanoma. The problem is compounded because people often die from other common causes, like heart disease, before these indolent cancers ever become clinically relevant. But screening finds them, labels them as cancer, and often leads to treatment.
That sounds like a huge problem. What's the last bias mentioned? Selection bias.
Also called the healthy volunteer effect. People who choose to participate in screening programs or trials often differ systematically from the general population. They tend to be more health conscious, perhaps have healthier lifestyles, better access to care. As a result, they may have a better prognosis and lower mortality rates regardless of the screening itself. This makes the screen group look better, but it's not necessarily due to the screening test.
Okay, so lots of ways the data can be misleading. Beyond biases, there are also direct potential drawbacks or harms of screening itself.
Yes, the source lists several. First, harm caused directly by the screening intervention, like radiation exposure from CT scans or mammograms, or discomfort, bleeding, or even perforation from procedures like colonoscopy or sigmoidoscopy.
Who else?
Harm from the further investigation needed for positive tests, both true positives and false positives. This includes patient anxiety, more imaging, invasive biopsies, and the potential complications from those follow-up procedures.
And harm from treatment.
Yes, harm from the treatment of true positives, even if that treatment doesn't ultimately extend life. Cancer treatments like surgery, radiation, and chemotherapy all carry their own risks, side effects, and impact on quality of life. The text makes a sobering point. Even when screening does reduce cause-specific mortality by a significant amount, say 15–30%, that still means 70–85% of the people diagnosed through screening still eventually die of that target cancer. Treatment isn't always curative, even with early detection.
And the harm from treating overdiagnosed cancer seems particularly important.
Absolutely. Treating an overdiagnosed cancer means subjecting someone to unnecessary treatment with all its costs, risks, and side effects for a condition that would never have harmed them. Plus, they bear the significant anxiety and psychological burden of a cancer diagnosis unnecessarily. When applied to millions of people in a screening program, this psychosocial impact can be substantial.
Given all these potential biases and harms, how do we rigorously assess whether a screening test is actually beneficial overall?
Good clinical trial design is essential to try and minimize these biases and get a clear picture.
And the strongest evidence comes from
Randomized controlled trials, RCTs, where the primary endpoint, the main outcome measured, is cause-specific mortality death from the cancer being screened for. The text also says overall mortality should be reported too.
Why overall mortality as well?
To check for unintended consequences. A screening program might reduce deaths from the target cancer, but accidentally increase deaths from other causes, maybe due to complications from diagnostic workups of false positives or side effects of treating overdiagnosed cases. Looking at overall mortality helps ensure there's a net benefit to lifespan.
How is the ideal RCT set up?
You take two comparable populations, randomly assign one group to receive the screening intervention being tested, and the other group to receive usual care, which might include no screening or whatever standard practice. Then you follow both groups over many years and compare the death rates from the target cancer. Efficacy is shown if the screened group has a statistically significant lower cause-specific mortality rate.
What about other kinds of evidence, like showing fewer late-stage cancers?
The text considers evidence like a reduction in advanced stage disease incidence, improved survival measured from diagnosis, or just seeing a shift towards earlier stage diagnosis as weaker evidence. These can be early indicators, but they are prone to the biases we discussed, lead time, length bias, and are not sufficient on their own to establish the true value of a screening test. You really need that mortality data from an RCT.
Are RCTs perfect?
Not perfect, no. If they aren't population-based, there might be questions about whether the results apply to everyone in the real world, generalizability. And they are very large, require thousands of participants, take many years, sometimes decades, to get definitive mortality results, and are incredibly expensive.
So sometimes other study designs are used?
Yes. Less definitive designs are often used to try and estimate effectiveness, especially when RCTs aren't feasible. But the source includes a very strong warning. Every non-randomized study is subject to strong confounders that can seriously bias the results and lead to wrong conclusions.
Is there a hierarchy of these less definitive studies?
Yes, the source lists them in descending order of strength. Internally controlled trials where allocation isn't truly random, then analytic observational studies like case control or cohort studies, and finally, multiple time series studies. Understanding this hierarchy and the limitations of each is critical for interpreting screening research professionally.
Okay, wow. That's a very thorough grounding in the principles and pitfalls of screening. Armed with that, let's dive into screening for specific cancers, looking at the evidence discussed in the text and comparing the recommendations from major organizations like the USPSTF and the ACS using Table 73. Let's start with breast cancer screening.
Okay. The tools discussed are breast self-examination, BSE, clinical breast examination, CBE, by a provider, mammography, MRI, and the newer technique, tomosynthesis or 3D mammography.
What's the evidence for mammography in average-risk women aged 50 and older?
Several randomized trials suggest a mortality decrease in the range of 15–30%. However, the text notes these older trials have faced significant criticism regarding their design, methodology, and the quality of the mammography used back then.
What about for younger women? Average risk, say age 40–49. That seems to be where the controversy lies.
Exactly. Experts disagree, and guidelines differ significantly here. The UK age trial, which specifically randomized women aged 40-49, did not find a statistically significant difference in breast cancer mortality after about 11 years of follow-up, though participation in screening wasn't optimal in that trial.
What about combining trials, meta-analysis?
A meta-analysis of 9 trials looking at women aged 39-49 found a small 8% relative reduction in mortality, relative risk 0.92, after 11-20 years. That translates to preventing about 3 breast cancer deaths for every 10,000 women screened over 10 years. Importantly, this finding was not statistically significant.
And the harms of screening in this younger age group?
They are considerable. The text states that with annual screening starting at 40, nearly half of women will experience at least one false positive result over a decade, requiring further evaluation, often including anxiety-provoking biopsies.
And overdiagnosis. Is that a big issue in breast screening?
It appears to be a major issue. Estimates vary widely, but some suggest that anywhere from 10% to perhaps as high as 50% of invasive breast cancers detected by screening might represent overdiagnosis cancers that would never have caused symptoms or death.
What's the evidence for that?
A key observation noted in the source is that since widespread mammography screening began in the U.S., there's been a huge increase in the diagnosis of early-stage cancers, but not a corresponding decrease in the incidence of metastatic, late-stage breast cancer. This strongly suggests that a substantial portion of the early cancers being found are, in fact, overdiagnosed cases that weren't destined to progress.
The text also mentioned treatment advances.
Right. It provides important context. Substantial improvements in systemic therapies for breast cancer, like chemotherapy, hormone therapy, targeted therapies, over the past few decades have likely played a very large role in the falling breast cancer mortality rates. This probably means the relative impact of finding cancer earlier via mammography on reducing mortality is less now than it might have been before these effective treatments were available.
What about the newer 3D mammography, tomosynthesis?
It's a newer method. We have evidence on its test characteristics. It seems to find slightly more cancers and might reduce recall rates compared to standard 2D mammography. But the source is clear. There is currently no data on its impact on actual health outcomes like morbidity, mortality, or, crucially, the rate of overdiagnosis. A large randomized trial directly comparing it to standard mammography is ongoing to answer those questions.
And breast self-exam. Does that help?
The evidence says no. The source states explicitly that no study has shown that teaching or performing regular BSE decreases breast cancer mortality. A large randomized trial in Shanghai actually found no difference in mortality compared to controls, but the women doing BSE had more benign lesions detected and more biopsies performed. So potential harm with no proven benefit.
What about screening for high-risk women, like BRCA carriers?
Genetic screening identifies these women, but the text notes that the optimal screening strategy, when to start, how often, which tests has not been definitively defined. Mammography sensitivity is known to be lower in these women, partly because they are often younger and have denser breast tissue, making cancers harder to see.
Is MRI better for them?
MRI may be more sensitive than mammography in high-risk women or those with dense tissue generally, but its specificity tends to be lower, leading to more false positives and follow-up investigations. And there's a concern that this increased sensitivity may also increase overdiagnosis. Crucially, no randomized controlled trial has evaluated whether using MRI, either alone or with mammography, actually reduces breast cancer mortality in these high-risk women.
Okay, let's try to summarize the USPSTF versus ACS recommendations from Table 73. They differ, right?
They do, especially for ages 40-49. USPSTF gives a C recommendation for this group, meaning the decision to start biennial screening before 50 should be an individual one based on a woman's values regarding the potential benefits versus harms like false positives and overdiagnosis. They give a B recommendation for biennial screening for ages 50-74.
And ACS.
ACS recommends women have the option to start annual screening at age 40, strongly recommends annual screening for ages 45-54, and then recommends transitioning to biennial screening or continuing annual screening for women 50 out and older as long as they are in good health.
What about clinical breast exam or MRI?
Both USPSTF and ACS recommend against relying on CBE for screening. For MRI in high-risk women, defined differently but generally 20-25% lifetime risk, ACS recommends annual MRI in addition to annual mammography. USPSTF currently gives an I, insufficient evidence, for MRI screening based on older data reviews. Neither organization currently recommends tomosynthesis over standard mammography based on outcome data.
So quite a bit of difference in complexity there. Let's move to cervical cancer screening.
Here, the evidence is much clearer regarding benefit. The primary tool is the Pap test cytology, looking for abnormal cells on the cervix. The source states unequivocally that widespread use of Pap testing has substantially decreased cervical cancer incidence and mortality rates. HPV infection is identified as the key causal factor.
When should screening start?
Guidelines consistently recommend starting regular screening at age 21. Screening women before age 21, even if they are sexually active, is generally discouraged because it may cause more harm than benefit. Young women often have transient HPV infections and related cell changes that resolve on their own, and screening them leads to unnecessary procedures and anxiety.
How often?
For women 21-29, the recommendation is cytology, Pap test, alone every 3 years. Screening more frequently adds little benefit but increases harms.
What about women 30 and older?
Starting at age 30, guidelines incorporate HPV testing, since persistent high-risk HPV infection is the main driver of cervical cancer. One option is co-testing, doing both a Pap test and an HPV test together. If both are negative, the screening interval can be safely extended to 5 years. Other options presented in the source for ages 30-65 are primary HPV testing alone every 5 years, or continuing with cytology alone every 3 years.
When can women stop screening?
The optimal upper age limit isn't precisely defined, but women over age 65 who have had adequate prior screening with consistently normal results, no abnormal tests in the past 10 years, can generally consider stopping. Screening should also be discontinued after a total hysterectomy, removal of cervix and uterus, done for benign reasons.
Any caveats about the evidence for Pap testing?
Just an interesting historical note mentioned in the text. The efficacy of the Pap smear itself in reducing mortality was never directly confirmed in a large randomized controlled trial like we see for other screening tests. Its effectiveness was largely inferred from observational data showing dramatic drops in cervical cancer rates after screening was widely introduced. However, supportive evidence comes from trials like a clustered RCT in India, which showed that even simpler visual inspection methods could reduce cervical cancer mortality, backing the general principle of screening for this disease.
How do the USPSTF and ACS recommendations compare here, Table 70-3?
They are very closely aligned for cervical cancer. Both recommend against screening under 21 and stopping after hysterectomy for benign disease. Both recommend cytology alone every 3 years for ages 21-29. For ages 30-65, both list cytology alone every 3 years, or are co-testing, Pap plus HPV, every 5 years as preferred options. USPSTF also explicitly lists primary HPV testing alone every 5 years as an acceptable strategy for this age group. Both recommend against HPV testing in women under 30 for screening purposes. So, broad agreement here.
Good to see agreement somewhere. Okay, let's tackle colorectal cancer screening. This seems like an area with lots of different test options.
It is. The source discusses several accepted tools. Guaiac-based fecal occult blood test, GFOBT, the newer fecal immunochemical test, FIT, multi-targeted fecal DNA testing, digital ripple exam, DRE, though not really a primary screening tool anymore, flexible sigmoidoscopy, colonoscopy, and CT colonography, virtual colonoscopy.
What's the evidence for the stool-based tests like FOBT or FIT?
For the older GFOBT, a meta-analysis of 5 RCTs showed that biennial, every other year, screening reduced colorectal cancer mortality by about 22%. Annual screening showed a larger reduction, around 32% in one trial. The DOT, the source, points out a major limitation, the high rate of false positives with GFOBT. Only 10% of people with a positive test actually have cancer or significant polyps, which leads to many follow-up colonoscopies in people without disease.
Is FIT better?
FITs generally have higher sensitivity for detecting colorectal cancer than GFOBT, and may have better specificity too, meaning fewer false positives. However, the text notes some limited observational evidence suggesting FIT might be less effective at detecting tumors on the right side, proximal of the colon, compared to the left side, distal.
What about the fecal DNA tests? They sound high-tech.
Multi-targeted stool DNA tests, like Cologuard, combine FIT with tests for specific altered DNA markers shed from colorectal tumors or polyps. Limited evidence suggests a single test has higher sensitivity than FIT alone, particularly for advanced polyps. But its specificity is lower than FIT, resulting in more false positives and thus more follow-up colonoscopies. A key limitation highlighted is that there are currently no studies evaluating its effects on colorectal cancer incidence, morbidity, or mortality over time compared to other strategies.
Is there a blood test for colon cancer screening?
A blood test looking for methylated S-septenine DNA is commercially available. However, the source notes it has low sensitivity, particularly for polyps and early-stage cancers, and lacks longitudinal data on performance or outcomes. It is not recommended as a first-line screening test.
Okay, moving to direct visualization tests. Sigmoidoscopy.
Flexible sigmoidoscopy examines just the lower third to half of the colon. Meta-analyses of several RCTs have shown it reduces colorectal cancer incidence by about 18% and mortality by about 28% when offered to people aged 50-74. If polyps are found during sigmoidoscopy, a full colonoscopy is then needed to examine the rest of the colon.
How often should sigmoidoscopy be done?
The optimal interval is debated, but every 5 years is often recommended, sometimes combined with annual stool testing, FIT. Case control studies suggest the protective benefit might last up to 10-15 years after a negative exam. A large UK trial even showed a significant mortality reduction from just a one-time sigmoidoscopy screening offer around age 55-64.
And the gold standard, colonoscopy, examines the whole colon.
Yes. A single screening colonoscopy detects about 25% more advanced lesions, cancers or large polyps, than a single round of FIT plus sigmoidoscopy. However, the text states that the comparative performance of a programmatic strategy of repeated colonoscopy versus other repeated screening methods over the long term is unknown from trials.
Are there downsides to colonoscopy?
It's more invasive, requires a full bowel preparation, sedation is usually needed, and it carries a higher risk of complications like perforation and the tear in the colon wall, about 4 per 10,000 procedures compared to maybe 1 per 10,000 for sigmoidoscopy. There's also ongoing debate about cost effectiveness and whether healthcare systems have the capacity to offer it as the primary screening method for everyone.
Does it work equally well throughout the colon?
That's a key point of recent research. Evidence suggests that the effectiveness of colonoscopy in reducing colorectal cancer incidence and mortality is primarily limited to cancers arising on the left side, distal colon and rectum. Its ability to prevent right-sided proximal cancers appears to be much lower, possibly due to difficulties in detecting certain types of polyps there or incomplete exams.
What about CT colonography or virtual colonoscopy?
At expert centers, its sensitivity for detecting polyps 6 millimeters or larger is comparable to optical colonoscopy. But UT, a significant drawback mentioned, is the high rate of detecting incidental findings outside the colon in the abdomen or pelvis that require further, often costly and anxiety-provoking workup, even though most turn out to be benign. This happens in 5-37% of scans. The long-term cumulative radiation risk from repeated CT scans over a lifetime is also a consideration.
Okay, comparing USPSTF and ACS recommendations here, Table 73. Starting age seems different now.
Yes, that's a recent change. USPSTF strongly recommends a recommendation, screening for average risk adults aged 50-75. They give a C recommendation, individual decision, for ages 45-49, and also for ages 76-85. ACS, however, now gives a qualified recommendation to start screening at age 45 for average risk adults and a strong recommendation for ages 50-75. Both organizations then list a menu of acceptable screening strategies and intervals.
Well, a menu?
Yeah, reflecting the fact that there are multiple good options with different pros and cons. Both list annual high sensitivity, GFOBT or FIT, multi-targeted stool DNA every 3 years, flexible sigmoidoscopy every 5 years, or every 10 years if combined with annual FIT, colonoscopy every 10 years, and CT colonography every 5 years. The idea is to allow for shared decision-making based on patient preference, availability, and risk.
Okay, that makes sense. Let's move to lung cancer screening.
The tools considered here have been chest X-ray, examining sputum cytology, cells coughed up, and low-dose helical CT LDCT scans.
What about chest X-ray and sputum? Did those work?
No. The large PLCO trial definitively showed that annual screening with chest X-ray did not reduce the risk of dying from lung cancer compared to usual care over 13 years. Sputum cytology also failed to show benefit in earlier trials. Chest X-ray screening was also associated with significant overdiagnosis in PLCO.
So the focus shifted to low-dose CT scans.
Yes. The pivotal trial here is the National Lung Screening Trial, NLST. It was very large, randomizing over 53,000 current or former heavy smokers aged 55-74 to receive annual screening with either LDCT or standard chest X-ray for 3 years.
What did NLST find?
It found a statistically significant reduction in lung cancer mortality in the LDCT group compared to the chest X-ray group, about a 20% relative reduction, which translated to approximately 3 fewer lung cancer deaths per 1,000 high-risk individuals screened over the median 6.5 years of follow-up. Results extended out to 12 years later.
So a benefit, but what about harms with LDCT?
Significant potential harms are noted. These include the cumulative radiation exposure from repeated annual scans, though it's low dose. There's a high rate of finding incidental nodules or other abnormalities in the lungs or nearby structures that need further investigation, but turn out to be benign. The the false positive rate is very high. Over 95% of positive screens in NLST were false alarms.
And these false alarms lead to?
They lead to anxiety, additional scans, and often invasive procedures like needle biopsies or even surgery to rule out cancer, which carry their own risks like collapsed lung, pneumothorax, or bleeding hemothorax, plus cost and inconvenience. Overdiagnosis is also a concern with LDCT, though its magnitude is still debated.
The source also mentions context for NLSST.
Yes, it points out that NLSST was conducted at experienced academic centers with strict protocols and multidisciplinary teams. The balance of benefits and harms might differ when LDCT screening is implemented more broadly in community settings with potentially less expertise or resources.
How do the USPSTF and ACS recommendations compare for lung cancer screening? Table 73.
They have very similar criteria for defining the high-risk population eligible for screening, focusing on age and heavy smoking history. USPSTF gives a B recommendation for annual LDCT screening for adults aged 50-80. Note, updated age range, who have at least a 20-pack-year smoking history and currently smoke or have quit within the past 15 years. They recommend stopping screening once someone hasn't smoked for 15 years or develops a health problem limiting life expectancy or ability to have curative lung surgery.
And ACS.
ACS recommends annual LDCT for adults aged 55-74 with at least a 30-pack-year history, slightly different criteria there, who currently smoke or quit within 15 years. Crucially, ACS emphasizes the importance of shared decision-making after discussing benefits, limitations, and harms, and strongly recommends that screening only be performed in high-volume, high-quality centers with expertise in LDCT screening, diagnosis, and treatment of lung cancer.
So, strict criteria and emphasis on quality centers.
Okay.
Next, ovarian cancer screening.
The tools that have been evaluated here are primarily pelvic examination focusing on the adnexa, ovaries, and tubes, transvaginal ultrasound, TVUS, and the serum CA-125 blood test, sometimes used together or in algorithms.
What's the verdict on screening average-risk women?
The evidence base here is quite clear and unfortunately negative. Large randomized controlled trials, including the PLCO trial in the US and the UKCT-IDOCS trial in the UK, have definitively shown that annual screening using TVUS, CA-125, or a combination strategy does not reduce deaths from ovarian cancer in average-risk women. In fact, one trial showed a non-significant trend towards worse mortality in the screened group.
No benefit. What about harms?
Substantial harms were documented. The source highlights the high number of false positive results. In the PLCO trial, about 10% of women screened over several years had a false positive TVUS or CA-125 result. About a third of those women underwent major surgery, usually removal of ovaries and tubes, to investigate the finding. The ratio of surgeries performed for a positive screen compared to the number of screen-detected ovarian cancers was disturbingly high, around 20 surgeries for every one cancer found. These surgeries carry risks and costs.
Any regulatory action?
Yes. The source notes a significant FDA safety communication issued in September 2016. The FDA specifically recommended against healthcare providers using any currently available test, including risk prediction algorithms combining tests, to screen for ovarian cancer in the general population, citing the lack of proven benefit and the documented harms.
How do the USPSTF and ACS recommendations align?
They are in complete agreement here. Both organizations strongly recommend against routine screening for ovarian cancer in asymptomatic women who are not known to be at high risk. USPSTF gives this a D recommendation, meaning there's certainty the harms outweigh any potential benefits. ACS similarly states there are currently no reliable screening tests and notes that even for women known to be at high risk, for example, BRCA carriers, using TVUS and CA-125 for surveillance has not been proven to reduce their chances of dying from ovarian cancer, although it's often still done in specialized clinics.
Okay, very clear message there. Let's turn to prostate cancer screening, another controversial one.
Extremely controversial. The main tests discussed are the digital rectal examination, DRE, and the serum PSA, prostate-specific antigen blood test.
How has PSA testing impacted things?
Dramatically. The source notes that the widespread adoption of PSA testing since the late 80s, early 90s, made prostate cancer the most frequently diagnosed non-skin cancer in American men for many years. However, the disease and the PSA test are particularly susceptible to those screening biases we discussed earlier, lead time bias, length bias, and especially overdiagnosis.
So there's debate about even offering the test.
Yes. Significant debate among experts about whether PSA screening should be routinely offered or only discussed if a man brings it up. Most major organizations now stress the critical importance of shared decision-making, meaning men need to be informed about the significant uncertainty regarding the test's efficacy in saving lives, and the well-documented potential harms associated with screening, diagnosis, and subsequent treatment before deciding whether to be tested.
Does PSA screening clearly find cancers?
Oh, it clearly detects many asymptomatic prostate cancers, yes.
Yeah.
The problem is its major limitation. It has very limited ability to distinguish between the aggressive, potentially lethal cancers that might benefit from early detection and treatment versus the large number of indolent, slow-growing cancers that pose little or no threat to a man's health during his lifetime.
And these slow-growing ones are common.
Very common. The source notes autopsy studies find indolent prostate cancer in 30-50% or even more of men over age 50, and the prevalence increases with age. Most of these men die with prostate cancer, not from it.
What have the large mortality trials shown?
2 major RCTs provide the main evidence, with somewhat conflicting results adding to the controversy. The U.S.-based PLCO trial randomized men aged 55-74 to annual PSA screening, plus DRE, or usual care. After 13 years of follow-up, there was no statistically significant difference in the number of prostate cancer deaths between the screen group and the usual care group. However, a major limitation was that many men in the usual care group actually got PSA testing outside the trial contamination, which might have diluted any potential benefit of organized screening.
And the European trial, ERSPC.
The ERSPC was larger, multinational, and compared PSA screening at intervals of 2 over 4 years to no screening. In the core age group analyzed, 55-69, after a median follow-up of 15.5 years, they did find a statistically significant 20% relative reduction in the risk of prostate cancer death in the screened arm.
So that sounds like a benefit.
It is statistically significant, yes, but the absolute benefit was small. The text notes you'd need to invite 570 men to screening and detect 18 prostate cancers through that screening to prevent just 1 death from prostate cancer over that period. The trial also had some methodological issues, including an unexplained imbalance where men diagnosed in the screen arm were more likely to receive aggressive treatment at specialized centers, which could have influenced the outcome.
And does screening need effective therapy to work? What about treatment for early prostate cancer?
Absolutely. Screening is only useful if it leads to treatment that improves outcomes compared to later diagnosis. The source mentions trials comparing active monitoring or watchful waiting versus radical treatment, surgery or radiation, for men diagnosed with low-stage prostate cancer, often found through PSA screening. These trials, like PVIT in the U.S., found that survival at 10 years was nearly identical, around 99%, and very good in both groups, suggesting that for many men with low-risk screen-detected cancer, immediate aggressive treatment may not offer a survival advantage over careful monitoring, but it does carry significant side effects.
What are the harms of treatment?
For low-stage prostate cancer, surgery, radical prostatectomy, and radiation therapy cause substantial rates of long-term morbidity, most notably sexual dysfunction, erectile dysfunction or impotence, and urinary incontinence, leakage. These can significantly impact quality of life.
So putting it all together, how do USPSTF and ACS recommendations compare? Table 73.
They reflect the uncertainty and emphasize individualized decisions. USPSTF gives a C recommendation for PSA screening for men aged 55 to 69. This means the decision to undergo periodic PSA screening should be an individual one, made after a discussion with their clinician about the potential benefits, small chance of reducing risk of dying from prostate cancer, and harms, false positives, overdiagnosis, treatment side effects. They specifically recommend against screening men in this age group who haven't expressed a preference for it. And they give a D recommendation, recommending against PSA screening altogether for men age 70 and older.
In ACS.
ACS focuses heavily on shared decision-making. They recommend that this conversation should begin at age 50 for average-risk men who have a life expectancy of at least 10 years. They recommend starting the discussion earlier at age 45 for men at higher risk, including African-American men and those with a first-degree relative, father or brother, diagnosed before age 65. And even earlier, age 40, for men with more than one first-degree relative diagnosed at an early age.
And if a man decides to be screened,
ACS recommends that screening, if chosen after the discussion, should be done with a PSA test. The DRE is considered optional. The frequency of testing then depends on the initial PSA level, evaluated every 2 years if PSA is low, maybe annually if higher. USPSTF doesn't specify frequency or comment on DRE separately, so both emphasize the discussion, but ACS provides more specific guidance based on risk factors for initiating that talk.
okay, a very nuanced picture for prostate cancer. Finally, skin cancer screening.
This typically involves a healthcare provider or the patient themselves doing a visual examination of all skin surfaces, looking for suspicious moles or lesions that could be basal cell carcinoma, squamous cell carcinoma, or melanoma.
What's the evidence for mortality reduction?
Simple answer. There isn't any from strong studies. The source states clearly that no prospective randomized study has been conducted to determine if routine visual skin examination, either by a clinician or by patient self-exam, reduces mortality from skin cancer, including melanoma.
Any known drawbacks?
Yes, a significant drawback mentioned is that visual skin screening is associated with a substantial rate of overdiagnosis, particularly for early-stage melanomas or less aggressive non-melanoma skin cancers that might never have progressed or caused harm. This leads to many biopsies and excisions of benign or indolent lesions.
What do the guidelines say? Table 73.
Reflecting the lack of evidence for benefit and concerns about overdiagnosis, USPSTF gives an I recommendation for visual skin examination by either a clinician or the patient for adults of all ages. I means the evidence is insufficient to assess the balance of benefits and harms. ACS simply lists no guidelines for routine skin cancer screening in the general population, though they do recommend awareness of skin changes.
Wow. Okay, that is an incredibly detailed journey through prevention and detection for specific cancers. It really drives home just how varied the evidence is, from clear benefit for some things, like cervical screening, to huge uncertainty and controversy for others, like prostate or even breast screening in younger women.
It absolutely does. And to really achieve that mastery level understanding we talked about at the start, it's helpful to integrate the brief but fundamental material from Chapter 71 that was included in our source file. It talks about the underlying genetic basis of cancer, which really reinforces why these prevention and detection strategies target what they do.
Right, connecting the dots back to the biology. What does Chapter 71 say?
It starts with a very clear fundamental statement. Cancer is, at its core, a genetic disease. It arises through somatic alterations, changes to the DNA in our body cells that happen after we're conceived, which ultimately lead to cells growing and dividing without restraint.
And these alterations are mutations?
Mostly, yes. The text explains most alterations are subtle changes in the DNA sequence, called mutations. These somatic mutations can occur randomly just from errors during normal DNA replication, or they can be caused by exposure to carcinogens, things like radiation or chemicals we discussed. And the risk is amplified if a cell's DNA repair machinery isn't working properly to fix these errors.
What about inherited versus sporadic cancer?
While most cancers are sporadic, meaning the crucial mutations happen somatically during a person's lifetime, the text mentions that some cancers do cluster in families. This often happens when individuals in the family inherit a germline mutation, a mutation present in every cell, passed down from a parent in a gene that plays a critical role in preventing cancer. This inherited mutation gives them a sort of head start down the path towards developing cancer.
The text gives a little history, too.
Yeah, a brief nod to how understanding evolved. From early, vague ideas about cancer being related to mucus or weird aggregates, to recognizing it as masses of cells coming from normal tissues. Early theories involved things like combustion or the idea that maybe all cancers were caused by viruses.
But the modern understanding came from linking environment to DNA changes.
Exactly. Observations like chimney sweeps getting scrotal cancer, radiologists getting skin cancer, the overwhelming data linking cigarette smoke to lung cancer, all pointed towards environmental exposures causing the disease. Then, lab tests like the Ames test showed that known carcinogens could indeed cause mutations in DNA. The genetic basis was definitively established when scientists were finally able to identify the specific somatic mutations present in tumor cells at the molecular level.
Did the virus theory completely disappear?
Not completely. While not generally accurate for most human cancers, there are those important exceptions we talked about, like HPV causing cervical cancer. And interestingly, the study of certain animal retroviruses actually led to the discovery of the first human oncogenes back in the late 1970s. Oncogenes are one of the two major classes of genes that, when mutated, actively drive cancer growth.
And the other class came from studying families.
Right. Studying families with high rates of inherited cancers was key to discovering the other major class, tumour-suppressor genes. These genes normally act like brakes on cell growth. When they are mutated or lost, the brakes are released, allowing cells to divide uncontrollably. Modern genome sequencing technology now gives us an incredibly comprehensive view of all the mutated oncogenes and tumor-suppressor genes in an individual cancer. The whole field is known as cancer genetics.
And two key concepts mentioned are clonal origin and the multi-step nature.
Fundamental concepts. Clonal origin means that nearly all cancers arise from a single ancestral cell that acquired an initial advantageous mutation. But that single mutation is almost never enough. Cancer development is a multi-step process, requiring the accumulation of multiple mutations over time for a tumor to progress from a normal cell through various precancerous stages to become a fully malignant, invasive cancer.
It's like evolution happening within the body.
Exactly. The text describes it as Darwinian microevolution at the cellular level. At each step, a cell acquires a mutation that gives it a slight growth or survival advantage over its neighbors. It expands to form a clone, creating a larger pool of cells where the next advantageous mutation can occur. The text even references early mathematical models from the 1950s by Armitage, Dahl, and Nordling, which predicted, based on how cancer rates increased with age, that cancer likely resulted from about 3 discrete cellular changes. Remarkably, modern genome sequencing has largely validated this, showing that most common solid tumors need mutations in a minimum of about 3 to 5 key driver genes, a mix of activated oncogenes and inactivated tumor suppressors to become malignant.
So how does understanding this genetic basis tie everything together? Prevention, detection?
It provides the scientific rationale. Understanding that cancer starts with DNA damage reinforces prevention strategies aimed at avoiding initiators and carcinogens stop the mutations from happening. Understanding the multi-step process involving specific gene pathways provides targets for chemoprevention agents that might interfere with promotion or progression. And for detection, it helps explain why finding cancer early, when it presumably has fewer accumulated mutations and is genetically less complex, might offer a better chance for cure. It also reinforces why identifying individuals with inherited germline mutations is important. They've already taken one step down that multi-hit path, putting them at higher risk and making them logical candidates for more intensive prevention or detection efforts.
Okay, that really synthesizes it well. This has been an incredibly deep dive. We've covered such a range of prevention strategies from lifestyle up to specific agents, vaccines, surgery, then all the screening tests, the imaging, lab tests, visual exams.
And crucially, the evidence behind them, or lack thereof sometimes.
Right. We've really highlighted the mixed evidence, how for so many of these interventions and tests, it's just not clear-cut. The evidence is often conflicting or shows maybe limited benefit but significant harms. We saw that with some chemoprevention agents like beta-carotene, the complexities of diet studies, and particularly the issue of overdiagnosis with screening for prostate, breast, maybe skin cancer, and the harms of treating those potentially indolent cancers.
Absolutely. It underscores why individual context and shared decision-making are just so critical. Screening recommendations, as we saw, are rarely simple yes-no answers. They often have nuances based on age, risk factors, smoking history, family history.
And the fact that different expert groups like USPSTF and ACS sometimes arrive at slightly different recommendations based on the same body of evidence.
That really highlights the ongoing debate, the different ways of weighing benefits and harms, and the need for personalized decisions made between a patient and their clinician, considering the individual's risk tolerance, their values, alongside the best available and often imperfect scientific data.
So for our listener aiming for that mastery level understanding, what are the absolute critical concepts to take away?
I think it goes beyond just listing tests. Elite professionals in this field really understand the principles. They grasp the multi-step nature of carcinogenesis and where interventions might work. They appreciate the limitations of observational studies versus the strength and limitations of RCTs. They understand deeply the specific biases inherent in screening lead time, length bias, overdiagnosis, selection bias, and how easily these can mislead us.
And the difference between just finding disease early and actually making people live longer or better.
Exactly. That distinction is fundamental. And finally, it's about constantly weighing that balance, the potential benefits versus the documented harms for each specific intervention or test applied to a specific population or individual. It's rarely black and white.
Which puts a huge responsibility on the clinician.
It does. Not just to provide information, but to help patients navigate this incredibly complex evidence base, interpret it in light of their own situation, and make genuinely informed choices based on the best, though often imperfect, data we have.
Well, we have certainly taken a deep dive today. We've explored this really multifaceted world of cancer prevention and early detection, starting from the genetic basis all the way through lifestyle, drugs, vaccines, surgery, and the complex realities of screening.
It's definitely clear this field is constantly evolving. New research keeps challenging old assumptions, refining our understanding, and highlighting just how nuanced the questions of what works and for whom really are.
And considering everything we've discussed about the prevalence of overdiagnosis, the significant harms that come from diagnosing and treating cancers that might never have caused problems, which seems particularly relevant for prostate cancer screening, and a growing concern for breast, thyroid, and skin cancer screening too. It really makes you pause and think.
Where should the focus be?
Right. Perhaps the future of cancer control lies less in this drive to find absolutely every single cellular anomaly as early as technologically possible.
And maybe more towards developing highly sophisticated methods, maybe based on molecular signatures or AI, that can reliably distinguish the truly dangerous, aggressive cancers that need immediate, effective treatment from those numerous slow-growing or indolent ones that will likely never cause harm if left alone.
That capability, combined with maybe a renewed and intensified focus on implementing proven population-level prevention strategies, things we know work, like comprehensive tobacco control, addressing obesity, promoting HPV vaccination. Maybe that combination is the most impactful path forward.
It forces us to ask that provocative question you raised earlier.
What does early detection truly mean if a significant portion of what we're detecting early includes diseases that would literally never impact a person's health or lifespan?
A question that continues to fuel intense research and ethical debate in the field.
Indeed. It's a lot to think about. Thank you for joining us on this deep dive into the complex, challenging, but incredibly important world of cancer prevention and detection.